Good morning. This is Senate Health and Welfare, this committee meeting. It is February 16th, and today we are continuing our work on two bills. One is H654. We're going to hear what we hope to be some final testimony on that bill. And then we're going to move on to S90 and get comprehensive testimony on that bill as well. We will have a hard stop at 10:30. I'm hopeful that we'll have some time after we hear testimony on H654 for a little discussion with Jen. So that's our plan. And welcome, Mike Fisher. It's good to see you here. And we welcome your testimony.
Thank you. Good to be here. As you maybe can tell, I'm sitting in your room.
Yes, you are. I could recognize the painting.
I think I might be in Senator Cummings' seat. And thankfully, there's nobody here, so I can take my mask off. I appreciate having a moment to testify on this bill, and I think I can be very brief. And I did provide a written statement that I'm not going to attempt to cover in any detail, even though it's a very brief, simple statement. We generally support the provisions of H654 as passed by the House. I was asked to come and speak a little bit more specifically about, I think, Section 9, and I have very much the same statement. We don't know that there are many people taking advantage of the flexibility that this provision provides for. But we still think at this time it's an important flexibility for Vermonters who are taking what actions they feel are necessary to protect themselves from COVID exposure. So having an ability to do an early refill and a 30-day fill continues to make sense to us, and I think that is really as much as I need to say. We received some cases early in the pandemic from people who were struggling with this, less so now. It's hard for us to know whether that's because their needs are being met or exactly why we're seeing fewer of those cases, but we think this is a good provision.
Okay. Thank you. Committee questions for our healthcare advocate? All right. We did hear testimony from some of the private payers indicating that they thought there might be abuse related to this provision. Are you, I know that you're probably not in a place to actually see abuse, but have you heard anything along those lines?
No, and I heard that testimony, particularly over on the House side. I wouldn't have characterized their testimony as abuse. I think what I think I heard was a concern that people may be using this provision for something other than COVID related concerns. And I guess given the limitations of what scripts are included here, we're talking about maintenance medications for chronic conditions. It does not worry me if somebody is, and Jeff Hochberg can fill in the details of what meds we're talking about, if somebody is getting an early refill of a med that they need to keep themselves healthy.
Okay. Thank you.
Thank you.
All right. Any questions, committee? All right. Jeff, welcome. I don't think you've been here this year, so it's good to see you.
It's great to see you, Chairwoman, and thank you for having me. I did fade off there just as you were going live, and I think that just highlights the fact that I miss seeing you all. I'm getting tired of these Zoom meetings. But
we'll be back soon enough.
Yes, indeed. Hopefully. Fingers crossed. So for the record, Jeff Hochberg, Vermont Retail Druggists.
So,
Madam Chair, may I just interrupt one really quickly to ask Jen what section this provision is in the bill so I can find it?
Section 9.
Section 9. Okay, thank you.
Section 9. Good question. Okay, Jeff, why don't you introduce yourself for the record and then we'll hear your testimony.
Sure, thank you. So again, Jeff Hochberg, Vermont retail druggist. And real quickly, I'm going to echo mostly what the healthcare advocate articulated. We are largely in support. The pharmacy community is immensely supportive of this provision for several reasons. The landscape, we do have a continued threat. We thought we were over the hump before, and when this was first being discussed in the House, we were amidst the biggest surge Vermont has ever seen, and we were opposed to lockdown again. So we don't know what's around the corner. We need to be flexible. We need to be ready. And furthermore, though, is the fact that the landscape is showing that we have fading access to care, particularly in the pharmacy space. We have pharmacy closures at an all-time high from independent pharmacies and even the chain pharmacies, who are all looking to consolidate because financial stability is in serious jeopardy. 90-day maintenance dispensing is not as prevalent as this committee might think. There are still many plans who do not allow community pharmacies to dispense extended day supplies, which creates, again, more access issues and constraint to Vermont constituents. From a safety standpoint, pharmacists are still responsible, and they still uphold a duty, and they have a liability to ensure that medications are dispensed in an appropriate and safe manner. The OPR, who is responsible for overseeing them and can take requests for investigations of abuse, is still working. Last time I checked, in fact, I spoke to Carrie not too long ago. OPR is there, so the safety measures are there. The PBMs, who have their own safety tools, particularly around auditing, for overutilization and the such, those are quite in full force. In fact, desk auditing, the remote auditing, which is their utility is sometimes questionable, those have in fact, picked right back up to full steam. They still employ prior authorizations, and there's still an ability to even manipulate definitions to somewhat circumvent this maintenance, idea. It has not been widely utilized. But again, it creates a flexible option that the general public can discern for themselves and evaluate their own condition, where they are, and what's best for their families and themselves and their community. So it just makes good sense. And really, that's all I have to say. It's pretty straightforward.
No, that's helpful. Thank you. It's good to get your perspective on this, because you are very much attached to the patients who are getting this relief or flexibility. So do you have your testimony in writing? Could we get that?
I don't, but I'll happily send it over to you.
That would be terrific. Thanks. Questions, committee? Go ahead, Ruth. Senator Hardy.
Thank you, Madam Chair. And thanks, Mr. Hochberg, for your testimony. It's nice to meet you, or whatever this is. I'm curious about, the definition of maintenance medicine, and if you could explain that a little bit more. I mean, I do think that our concerns when we expressed this, when we chatted about this before, was the sort of safety issues about having extra medication around your home, especially maybe for older people who may have dementia or, concerns like that. Also families with young children, and just having extra medication around isn't always safe. And then the other concern was about the cost. If, people are having extra medicine and maybe their prescription changes midstream, and then they have leftover whatever. So could you just address those issues a little bit more and give us a better definition of maintenance medication?
Sure, and please stop me if I take you down any rabbit hole too quickly.
Okay.
So to start with the definition of a maintenance drug, there is none. There's none in any statutory language. There's none in any federal language, state, regulation, state rule. It is arguably a term that can be massaged and is massaged by payers, particularly the PBMs, for manipulation of rebates, for all kinds of various reasons, formulary considerations, what have you. So there is none. I couldn't tell you that, but I think the working definition and certainly the intent is that anybody that's been on a medication, for a chronic diagnosis, that medication should qualify. Insulin, for example, should qualify as a maintenance medication. Blood pressure medications, all of that.
What about medication for depression or anxiety?
Sure, absolutely. Those don't go away. Certainly not with a fading mental health care.
But it wouldn't include like amoxicillin or something like that.
Right. Antibiotics, no. Pain control, yes, there are chronic pain patients out there. So there are considerations. However, when you start getting into the scheduled legend drugs, you step into FDA and DEA territory where those are strictly regulated. So you cannot do early fills, and pharmacies do not push that out there. So there are stock gaps onto, for all these safety measures. Absolutely. To the point about,
I know you're going to keep going. Jen, did you want to dive in here or hold off?
Well, I was just going to give one additional clarification. Jennifer Kirby, Legislative Counsel. The definition that is used in the bill specifically excludes the regulated drugs, which is kind of Vermont language for controlled substances. So yes, there is the DEA aspect, but also it's just not even included in the scope of this. And I think that may include some medications for things like anxiety that may fall into what are regulated drugs.
And extremely dangerous. Anxiety medications, benzodiazepines in particular, actually have a greater repercussions when they are misused because they have so many drug interactions across the spectrum. So actually the holy trinity, as the DEA likes to call it, involves the benzodiazepines in association with an opiate.
And is that is a regulated drug?
Yes.
So
Yes.
Okay.
However, I mean, on the same token, so is buprenorphine and, your addiction therapies. They are abusable, but yet, this bill also does address the abilities for, further, tele refills and all that, refill authorizations, which is something that's needed. It's hard for patients to get into the doctor's office. So, it's a balancing act, but all those safety gaps are there without question. There is nothing at all that indemnifies or creates an opportunity for anybody to take advantage of this without serious repercussions. It's all there. In terms of the question about senior patients, senior patients are an issue. The geriatric community does have enhanced needs, which is why you see a lot of pharmacies actually doing away with traditional dispensing, using compliance packaging products, bubble packing, prepackaged medications. However, those also come with the fact that you don't do those in 90-day supply. Those are dispensed in 30-day supplies. And oftentimes, the way the insurance market's structured, we actually have to get an override from the insurer to allow a 30-day because they want those maintenance medications at 90 days to try to reduce costs in terms of dispensing things. So it's kind of like not quite sure where we are. It depends on which angle we're looking at it. But that's a consideration and not one that I think pertains to this measure. This measure does not stop that. Pharmacies are continually trying and striving to promote geriatric care. or for patients with mental disabilities to where they have difficulties taking their medication regimens. And there's a lot of opportunity out there for other products and other services types. In terms of costs, if you want to talk about the biggest waste of cost, I see it in the mail order. My stores are participating in the drug take-back boxes. We've been doing it since before the state actually got involved. We were one of the first here, and I fill up a container every month, which is 50 to 80 pounds worth of medications. We fill up a box every month, and it is largely from mail order programs. It goes back to, honestly, the way the system is designed. It's so backwards. Pharmacies, specifically in the Medicare D space, are actually penalized for not filling 90-day supplies of maintenance medications in some cases. These are what are referred to as a DIR fee measure, a star rating. And we often get requests for, the insurers say, well, why don't you dispense this at a 90-day supply, please? Trying to reduce costs, but it's a geriatric patient that's in a blister pack at an assisted living facility. It's like, no, we're not going to do it. But yeah, we'll take the penalty, no problem. But that's a federal issue, and they are actually tackling that this year. It's under serious investigation.
Okay, can I just do one quick follow up? So this bill, section 9, is to enable members to maintain a 30-day supply.
Right.
And what you're saying is that most maintenance drugs already are a 90-day supply. And
they're encouraged to do 90-day supplies in certain circumstances. It all depends on the payer and the market. So, Medicare D space is completely different from the commercial market, and completely different from the self-insured market. These are all the variations, which are quite frankly all hypocritical and inconsistent, are all designed by the PBM middlemen who they control.
Okay, so it's really stunning that we're like part of some of the people who designed this crazy system. Madam Chair, just like hearing you laugh about it is okay. So what I'm hearing then is that this provision probably only applies to a very, very small slice of people, and is probably not going to be used very much given where we are in the pandemic anyway, because most people are going out of their homes. And there's also, in my area at least, pharmacies are delivering to homes. So, okay.
Yeah.
Thank you, Mr.
Hopper. So long as the landscape continues trending, it's not going to be impactful. It's not abused, but again, it just creates that flexibility should things turn for the worse, and where the pharmacy that in your community has to close their doors. Even the chains, like they announced, CVS announced 1,000 stores they were closing. Walgreens, Rite Aid announced a whole bunch of stores, and independent pharmacies are closing their doors. So
it's like the meat packing industry.
Yeah.
Okay.
That's a bad analogy, but
I know. I just heard a story about the meatpacking industry yesterday and how it's all consolidated and how disturbing it is. So that's what brought to my mind. Not anything beyond that. All right. Thank you.
Okay. Thank you. Yeah, no, that's helpful. And we have a PBM. We have a whole bunch of, we have like 3 or 4 prescription drug bills on our wall, and we'll be going forward with a couple of them and hopefully see one from the House. So you may be back in our midst to help us plow through the complexity of the pharmacy and pharmacist industry. So thank you.
I thank you. I truly do hope that I'm back here.
I'm sure you will be. That's good.
There's been all kinds of developments, and federally, so it's going to be, it's a time for change. So
it sure enough is. Thank you. All right. So let's move on. We have some written information from Diva, and Nissa James is here. Nissa, thank you very much for putting together the information that we have on our webpage. And actually, it's about time you were in our committee. We're glad to see you. Going forward, we're probably going to be bringing you back again to talk a little bit about Medicaid and reimbursement issues. But for today, we're looking at H 654. And are you going to follow through with the testimony that you've given us? Why don't you introduce
I
yourself?
will.
Yep, go ahead.
Yes, Nissa James, for the record, Department of Vermont Health Access. And just to remind the committee, we're the state department who is responsible for administering Vermont's publicly funded health insurance plan known as Vermont Medicaid. And we also administer the state's health insurance exchange known as Vermont Health Connect. So hence I have requested to provide testimony today on two specific sections of H 654. If it's okay with you, Chair Lyons, I'd like to start with section 9 because that's where we left off with the two previous witnesses, and then I'd go to section 6.
That's just fine. Yes,
Wonderful.
any way you'd like. Yeah, good.
Perfect. So specific to section 9, as you have previously heard, Vermont Medicaid actually allowed this to be possible even before this language or the public health emergency. And so there's an override in our system that allows us to look at how often this is being used. And consistent with what you heard from the previous two witnesses, we certainly saw this being used more in the first 2 months of the COVID-19 public health emergency. Even during those first 2 months, it was somewhere between 1% and 2% of the total pharmacy claims that were processed. So it really wasn't well utilized, but it was available. Moving forward to the most recent data we have, we're seeing that this is used somewhere between 0.19% of all claims to maybe 0.27%. So what that translates as an example to is we might see this used on a monthly basis for approximately 274 pharmacy claims out of a total of 143,000. So we're not seeing this utilized much at all. But it did exist, as I said, and could be obtained if a pharmacist were to call into the pharmacy support center to ask for this. So I'm not here today to ask for this provision to be struck from the bill, but I am here to ask if we could amend the language slightly to make it more flexible. And that would really focus on ensuring that the language was permissive in accordance with earlier sections of the bill. So changing it to be something like, as an example, may allow or shall consider allowing, just to continue to allow that flexibility were this provision to be needed again. And so from the data perspective, we are not seeing this again utilized frequently. I think the concerns that we heard the committee state certainly resonated with us. So as I think you all are aware, our Vermont Department of Health participates in the National Drug Take Back campaign, and they have information that they share frequently around the fact that medications that are not properly stored in your home can be a risk to kids and to pets who could potentially ingest them. And the flushing of medications when we have medications sitting around, right, and that's a disposal technique, can be a danger to our environment. On the waste and fiscal impact side, for Vermont Medicaid, as you can imagine, the pharmacy benefit comes with a significant cost for Vermont Medicaid and for the state. And our department is responsible for effectively managing that. And so just to put it into perspective, our state fiscal year 2021 total drug gross spend was $231.2 million. So if there is the potential that prescriptions are being issued and just sitting around, there is both that safety concern, right, for being in the home, for the environment, and then we also want to make sure that we're responsibly utilizing Vermont taxpayer resources. So for all of those reasons, and per the data that we're seeing in our system, we would just request a slight modification to the language to make it permissive.
Okay, and that's, you have that recommendation on page 2, and it's the first bullet on page 2, so that's helpful. Okay, and just to clarify that right now, the utilization rate is 0.19 to 0.27%, 274 claims out of 143,000. So that's not a huge number. Yeah, okay. Senator Hardy.
Yeah, I just want to confirm, Nissa, you're looking at in paragraph B, instead of Vermont Medicaid shall, you want it to be Vermont Medicaid may. Is that the point where
Something
you're
like that.
asking for the change?
Correct. That would
Yeah,
be
okay.
our request.
When you testified in the House, did you make a similar request?
So we were asked to provide the agency, including Department of Vermont Health Access's perspective in a memo. Our memo was then reviewed by the committee, and the committee conversation indicated that they would like to keep the section as it was previously written. And so they did not make that change before they passed it out of committee, and then it obviously went to the House floor.
Okay, well, thank you. And as we're going through the bill, you, of all people, understand the expediency with which we need to pass this bill.
We do.
And so I will be reaching out to our counterparts in the House Healthcare Committee to determine how negotiable some of these requests are. So that's, yeah, in
Absolutely.
addition to our own thinking. So thank you. Okay. Why don't you go ahead?
Okay, so then I'm going to move to section 6, since it looks like there aren't any additional questions on section 9. And again,
Wait,
this is
Senator
where
Hooker has
we-
a question.
Oh,
I'm sorry, Nissa.
That's
When
okay.
you say flexibility, how flexible? I mean, if somebody really needs to have their prescription, a 90-day supply or whatever, is that individual going to be able to? Or do you do this individually, or is this what the department would do as a kind of blanket statement? Either allowing or not allowing that flexibility.
So this flexibility was actually in existence before this language was even in the bill. So what would happen is a patient would go into a Vermont Medicaid participating pharmacy. The pharmacist would call into the pharmacy support center. And this override that we have in the system could be used to issue the early refill if it was clinically appropriate to do
Okay,
so.
so it's essentially individuals. So they would be able to get it if an individual really needed it, they'd be able to get it. Okay.
Exactly.
And so that won't change whether the word is may or shall, or will it change?
It will not change.
Then, yeah, because that's an interesting question. So then the other question is suppose the
So why would
pharmacist
we be
is
asking
not,
for it?
yeah, that's trying to sort that one out.
Because of the concerns that we previously cited, particularly around the potential for waste and what the impact could be. Right now, we're seeing very infrequent utilization based on the data, right? But if we start to see something else as we're monitoring this on a monthly basis, that's why the permissive language would be helpful, so that we could be very clear that on an individual basis, this override might be allowed, but it's not broadly implemented.
Okay, that's helpful. Senator Hooker.
Thank you. Nisa, do you have an idea of, how often these claims are denied by Medicaid?
How often the specific override is denied?
Correct, yeah.
I would have to ask our pharmacy services director for that. I don't have that in the report of the number that have been processed.
Okay. If you could.
I'm happy to do that though.
Thank you.
But it sounds to me as if your concern is that if the volume increases, then you want to have some rate control over that increased volume.
That's exactly it.
But yet during the pandemic itself, when the volume was higher, it was shall. And have you heard of any abuses or waste as a result of the increased volume during the pandemic?
There are concerns about waste, and digging further into the data and seeing that this isn't being widely used by pharmacies across the board. It appears to be being utilized by a couple of specific pharmacies, but not generally.
And are those rural pharmacies?
I would need to double check whether those would be considered rural or Vermont urban.
Okay, all right, thank you. Jeff, I see you there, and I'm wondering if you could hold your comments until after Nissa has completed her testimony, and then we will circle back. Okay. Nissa, why don't you go ahead?
Okay, great. So I'm going to move to Section 6, Medicaid and Health Insurer Provider Enrollment and Credentialing. And the department's request here is similar to the request for Section 9. And it's really looking at ensuring that there's permissive language. So it would be shall consider relaxing, or may relax. And the reason being, and I think the committee is aware of this, although it's been a long time since we provided this testimony. So just for a little bit of background, once the public health emergency was declared, Vermont Medicaid submitted its Section 1135 waiver to the federal government in order to implement flexibilities in response to the COVID-19 public health emergency. And that was approved. And the flexibilities allowed for Vermont Medicaid to ensure a sufficient number of providers were able to serve Medicaid members by amending our provider enrollment requirements. So those are currently in place. But as we look forward to the public health emergency ending, we also need to be prepared for the federal requirement for Medicaid provider enrollment to re-begin. And for those of you who aren't familiar with that requirement, state Medicaid agencies have a requirement to revalidate the enrollment of providers, regardless of the provider type, at least every 5 years. And for Vermont Medicaid, our network is over 26,000 providers. And so we want to be very proactive in ensuring that we are continuing to process revalidations as providers can participate, to ensure that we don't end up with a backlog of providers who have to be revalidated in order to meet federal requirements and participate in the Medicaid program. Because if providers aren't revalidated, then we cannot have them seeing patients and being reimbursed for it by Vermont Medicaid. And that, as you know, will impact access. And so from our perspective, we want to ensure, as we're looking forward, that we're continuing to process those revalidations for our enrolled providers so that we don't end up with a backlog that could potentially impact both provider satisfaction with our program and also member access to care.
Okay. And then the question earlier, was this the same testimony presented to the House Healthcare Committee?
In the memo, correct. This was the
Okay.
other section that we
Okay.
identified a request for permissive. Yes.
All right, thank you. All right, Senator Hardy.
Thank you, Madam Chair. I just want to confirm that I understand the issue, Nissa. So your concern is if over the next year you continue not to be able to re-certify, is that the right word?
Enroll.
Enroll the
Whatever.
providers, that after March of 2023, you're just going to have a backlog of providers that you have to re-enroll, and you're not going to be able to, you'll just have a whole bunch of them. You won't have enough time to do it quickly. And so there will be sort of a gap where some of them aren't re-enrolled. Is that?
Yeah, that's a great summary. So as an example, right now, we are continuing to send out our revalidation notices so that providers know when their date is coming. And those go out 90 and 45 days prior to what the 5-year date would be in our system. And then we had a communication that went out to providers that said, you know, if you're encountering circumstances where you can't participate in this, please let us know, to indicate that it was a voluntary participation. That's allowed us to continue to reprocess about 525 of these revalidations a month to help prevent against that backlog. As an example, out of those approximate 525 that we're processing, we've only had 2 providers who called in and said, you know, we really need additional time. We're facing, you know, the surge and we can't undertake this burden right now. And then they were their revalidation was moved back.
Okay, so if you had the may versus the shall, you would still be able to tell those providers, okay, we get it. You can, and
Absolutely.
Would you do that? I'm assuming you would, but give them the
I would.
flexibility.
You have me recorded doing that. Yes, we would absolutely do that.
Okay.
I think
All
for
right.
us, part of the concern with the date in the first section, right, is also we just want to be really clear that our flexibility ends when the COVID-19 public health emergency ends, which is why that language has in there to the extent allowable by federal law. And so regardless of what date precedes that, once the federal public health emergency ends, that's when our flexibilities expire.
Oh, so it could be at any time, and then you would be forced to deal with any backlog.
This is part of our challenge, is it's unknown when it's going to end. And so we're trying to be really proactive in ensuring that we don't end up in a situation that actually would be contradictory to what this section is intending to ensure happens, right? So that latter part of the section says, in order to allow for individual healthcare providers to deliver and be reimbursed for services provided across healthcare settings, we agree, we don't want to impact that, and potentially having a backlog of providers whose enrollment or revalidation as terminated could absolutely impact that.
Yeah, okay, that makes sense. Thank
Okay.
you.
Yeah, thank you. That's great. A good explanation. It's very helpful.
And again,
Other-
we understand it's a negotiation, so we just wanted to make sure that you understood our perspective.
Yes, no, thank you very much. We appreciate it. And we don't know what the future holds in terms of the emergency ending or any changes in our own state. So, committee, other questions? Is there another section that you wanted to address?
No, those were the only
Okay,
two. I
that's
promised to keep it under 10 minutes. I hope I succeeded.
Oh, you did a good job. We appreciate that. Jeff, I know that you wanted to comment on the pharmacy section. Why don't we let that happen? And Nissa, you should stick around because it relates to what you were talking about.
Sure, thank you, Madam Chair. Maybe just to help the committee save some time and to understanding why the shall was in there, there was testimony in the House side regarding insurers' participation in this. There were several examples of insurers, particularly commercial insurers, that did not elect to allow 90 days at retail during the onset of the pandemic, and caused some frustrations amongst many providers.
Okay.
And I would just urge caution with the committee. There's a big distinction between may and shall, and whether or not it gets utilized or not. So I think that's kind of where it stemmed from, just so you have that understanding.
All right, thank you. That's helpful. Okay. All right, one more comment and then we're moving on. Go ahead, Mike. I just have to say, this makes me feel like we're sitting in the committee room having the conversation, which we've missed greatly being on Zoom, but go ahead, Mike.
Thank you, Madam Chair. And just very briefly, I would express something of an equity concern about the proposal. If you happen to have the provider who happens to be willing to support your request for an extended script or an early script, then you get it. And I just think I'll just stand by the original statement that I made, that during this time in particular, it makes sense for there to be a clear rule that allows for people to do this. And
Okay.
So that's my quick response.
Okay, thank you very much. All right. So committee, we've heard, I think we've heard about the controversial, in quotes, because doesn't sound like they're exceedingly controversial sections 6 and 9. So I would think it would be helpful for us to go through the bill, and we need to talk about 6 and 9 as a committee. So let's do that with Jen.
Okay, so did you want me to put the bill up
Yeah.
on the screen? Is that?
Yes, please. Yeah, that's
You
good.
want to look at the actual bill language is probably more helpful at this point than the.
Yeah, so I think that's what we should do. We haven't done that. We've looked at the table and where all these things have come from for the past how many years? 3 years. Oh.
Solid 2. Anyway.
I kind of feel like Sisyphus with this one. Maybe the next 4th year we'll be on to new horizons, over the top. Yes, ma'am.
I was just wondering if we could
Start
have
with
to go-
6 and 9.
Yeah, I was going to say, do we have to go through the whole bill again?
No, let's start with 6 and 9. That was it. I was going to
All right,
suggest
thank
that.
you.
Yeah, good point. Let's do it.
Okay.
So,
Senator Lyons,
yes, ma'am.
just question of clarification. This is an H bill. Is there a reason this needs to come out immediately?
Yes, remember the deadline for all the current flexibility provisions is March 31st, 2021. So this is a little more urgent than some of the other things.
Okay.
Yeah.
Thank you.
Yes.
It's my understanding, particularly from OPR and the Board of Medical Practice, that there's a lot of concern among providers about which provisions will be continuing.
Yeah.
For out of state and otherwise.
Yeah, so all the out-of-state licensure and everything, when we go through the whole bill, it'll remind us of why we're doing it now. So let's start with this one, Jen, to walk us through and be helpful.
Yes, so section.
Can you,
6
before you start, can you do one thing that would be very helpful to the committee? And that is, as we go through this, we see section 6, then we see section 8, then we see section something else. So could you explain the formatting of this?
Yes,
for
and
us,
I was
please?
actually just about to open the original for myself for exactly that purpose. Yes, so I'm going to go back up to the top of the bill for a moment here just to show you that we're in section 1 of H654, but that reaches back into several bills that were passed over the last 2 years, starting with Act 91 of 2020, and then that was amended by Act 140 of 2020, Act 159 of 2020, Act 6 of 2021, and Act 69 of 2021. So lots of changes have been made to Act 91, and that's because these provisions are in session law, so they're not codified in the statutes. We don't just go into the statute to make the change because these were anticipated to be fairly time limited when they were originally passed. They are in session law, so they're still good law, just harder to find, and we have to trace back through their history every time we make an amendment. So we're in section 1 of H654, but we're going reaching back into section 6 of Act 91. Does that help orient folks?
Oh, we are totally oriented.
Great.
Terrific. Thank you.
So sure, that was a great suggestion. And I was just pulling up Act 91 on my other screen in case there were any pieces of it that these little asterisks here were indicating, but that was just skipping over section 7. So section 6 from Act 91 as amended would require until March 31st, and this is currently in effect through 2022, but the bill would extend it until March 31st of 2023. And to the extent permitted under federal law, recognizing, as you heard from Diva, that much of what they do is governed by federal law. The Department of Vermont Health Access shall relax provider enrollment requirements for the Medicaid program, and DFR shall direct health insurers to relax provider credentialing requirements for health insurance plans in order to allow for individual healthcare providers to deliver and be reimbursed for services provided across healthcare settings as needed to respond to Vermonters' evolving healthcare needs.
Okay, let's stop right there. And so the request has been to change the shall to a may.
Yes, the request has been
Right.
to say shall consider, that DIVA shall consider relaxing provider
Yeah.
enrollment requirements.
But we heard that DIVA is capable of enrolling and that there only been a couple of folks who have asked for an extension. So I'm wondering how important that may or shall
Right.
consider.
I mean, what I will note here, and it may depend on how DIVA is interpreting this, but it does not specify what relaxation of provider enrollment requirements looks like. The idea here is to relax the provider enrollment requirements to allow for individual healthcare providers to deliver and be reimbursed for services across healthcare settings. So I don't know that it necessarily requires them to entirely stop the provider enrollment revalidations, but just to relax
the timing. It could be
requirements.
a timing
Could be
issue.
a timing requirement.
Yeah.
It could be, I'm not sure what all is involved in the in the process. But I think it may be possible to read some flexibility for DIVA into that language, the existing language.
Okay. So within the shall, there's some greater flexibility.
Well, because it doesn't define what relaxing the provider enrollment requirements is.
Okay.
It doesn't specify what is involved.
Committee comments here.
Madam, oh, sorry, go ahead, Senator.
Senator Cummings and Senator Hardy, just, go ahead.
I mean, our idea is to keep physicians functioning. And I'm not sure where the harm is in doing may. If the idea is to keep physicians available and all of a sudden there's such a backlog that people can't be credentialed, we've defeated our own purpose. I mean, what's the harm with may, I guess?
I'm not sure if there is a specific harm other than there's no requirement that DIVA offer any change from its standard processes for provider enrollment requirements. And you have heard from NISA on the record that they plan to continue being flexible. So that may not be of concern to the committee. I'm just not sure. I'm not sure either one is necessarily dispositive here. I think you can read either version to potentially allow flexibility both on the DIVA side and some assurance on the provider side.
So, Madam Chair, to that point, I wonder if we could just hear quickly from NISA whether that was their interpretation, or if there's a substantive difference on their side between shall and may. I mean, it seems like they do think there's a substantive difference, otherwise they wouldn't be asking for it. So I'm just wondering if we could hear from her. Is that okay?
Oh yeah, no, that's fine. She's still here.
Do you want me to take the language down or do you want to leave it up?
Oh, you can leave it up for now. I think it's helpful. NISA, are you there?
I am here. Thank you so much.
So you've heard you've heard the explanation of shall, and there's no definition of relaxation or so relax. So thoughts?
It's a great question. Our interpretation is actually consistent with the Office of Legislative Counsel's interpretation, but because it is an interpretation, that's where we are a little nervous, right? We want to make sure in the changes that we're making to plan for unwinding those flexibilities in preparation for the federal public health emergency to end and ensuring that our providers then meet the federal requirements, that we are moving in alignment with our partners in the legislature. And so from our perspective, the ability for interpretation is what has made us nervous, and that's why we requested the permissive language.
So I'm hearing you say that you're concerned that you're going to have a backlog of providers, but that hasn't happened even through the pandemic.
So during the pandemic, we have not had to meet that federal requirement for ensuring that our providers have been revalidated every 5 years. That's one of the flexibilities that we implemented. Once the public health emergency ends, we'll need to ensure that's met for providers to be enrolled and reimbursed from our program. So that's why we've continued to ask providers to participate in the revalidation process voluntarily during this time period. As an example, when we look back on 2021, for the providers that we asked to go ahead and renew all of their materials, we've had over 7,500 providers who have either enrolled or revalidated, and that's allowed us to keep from having a backlog.
So you're just, what you're doing for me is you're validating the shall, because it sounds like with the current conditions that providers are re-enrolling or being revalidated, and that there's not the backlog, and the decision as to what you're relaxing is up to DEVA. It's not something cut in stone. I mean, it can change. So help me here.
I'm not sure that everyone has that same interpretation. Our interpretation aligns with your understanding and with legislative councils. So if everyone is comfortable with that, then we could retract our request.
I'm feeling very comfortable with it, and think that what you've done through the pandemic, through our emergency, sounds like it's been very effective. I don't think there's a catch here. I really don't. Questions, comments, committee?
I mean, I think that it sounds like you're doing a great job. I hear you about being nervous about what if something happens and you get stuck. And that's totally reasonable, because none of us have been able to predict the future. And I know you're trying to just make sure that things don't get bad. And so I'm fine making it a May. I also think that if this holds the bill up and all that, then it's probably not worth it. And that we have all had this conversation live on YouTube, so we can all go listen to it and say, look, we think you have the flexibility right now to continue to do what you're doing and make sure that you don't get that backlog. So
okay, I will.
Fine.
Yeah. So I'll check in with House Healthcare, but I think given the definition or interpretation of to relax, I'm just fine with shall. If the House Healthcare Committee says no, go along, we'll go along with May, then we can decide to do that. But I don't want to hold the bill up for this. I really, hearing your comment, Nissa, and indicating that given the interpretation we've talked about, you'd be okay with shall, then I think we'll see what we can do, but.
Absolutely. And thank you for having this conversation, because that was really helpful.
Okay. It's helpful. Good. Well, I think you understand what we're trying to do. I mean, you want to maintain providers during the pandemic, but you also don't want to back the administration up so that they can't do their work. We understand that. Other committee members, Ruth is looking for May, Ann or Cheryl, Senator Hooker, Senator Cummings, thoughts here?
I'm fine with leaving shall.
Okay.
Yeah, Madam Chair, just to clarify, I'm fine with it. I think ideally, if we had all the time, I would slightly prefer May, but given this conversation, I'm more at ease with staying with the shall, because it sounds like they have the flexibility already.
Let's hope. Yes, I think they do. I feel, I agree with you on that. Okay. Let's head off to wherever section 9 may be.
All right. just a couple down. We're still in Act 91 as amended. So now we're skipping down to Section 9, which is the prescription drugs, maintenance medications, and early refills. So it starts off by defining health insurance plan, which is sort of our standard definition of a health insurance policy or health benefit plan offered by a health insurer as defined in a fairly expansive definition in 18 VSA 9402. So we're talking major medical is really what we're talking about. This then subsection B would extend through March 31st, 2023, with this requirement that all health insurance plans and Vermont Medicaid shall allow their members to refill prescriptions for chronic maintenance medications early to enable the members to maintain a 30-day supply of each prescribed maintenance medication at home. And then it defines maintenance medication as a prescription drug taken on a regular basis over an extended period of time to treat a chronic or long-term condition. And it does not include a regulated drug, which is a controlled substance.
Okay, thoughts here? No, after we listen to this a little bit, understand that the pharmacists are providing blister packs that don't conform to this requirement, and then also that a number of payers are providing for 90-day prescriptions. This one, and we haven't heard of a real problem.
Madam Chair.
Just go right ahead.
Okay. Again, I'm sort of in the same place with this one. I think ideally I'd prefer the May, just because of the concerns we raised with safety and cost. However, it seems like it's fairly narrow. There aren't that many people doing this. And so I'm a little bit more comfortable with it because of that. If we're able to get the May, I prefer it, but I also don't want to hold up the bill. So I'm fine either way, more or less.
Again, I'll talk with House Healthcare and just understand their passion for may or shall, or their passion for shall, I guess. And then but I agree with you. We haven't heard anything devastating here.
And I will just say, if you decide to pursue may, I think you may just as well repeal this section, because I don't think they need any authority. It was just the requirement that the plans and Vermont Medicaid allow their members to refill the prescriptions early. I mean, it may maybe highlights it, but it still doesn't expand authority beyond existing existing law. And I think you heard Vermont Medicaid has allowed their members to do this previously.
It's interesting because I've talked with folks who have been in this situation during the pandemic, and they felt quite a relief to know that they had the prescription on hand for that extra period of time. So if we don't know where we are right now, this is one of the problems. None of us can read the future, and so it is maybe it is something that offers reassurance going forward. And there are people out there who are still concerned about venturing out for one reason or another. Okay. Anybody passionate about may? Okay. So again, I'll reach out and talk with House Healthcare. Not hearing anything, we'll stick with the language that's here unless there's a willingness on the other side to change. Okay. Yeah, go ahead.
Chair, just a question. So are we going to try to pass this out this week? So
we sure are.
Yeah, good. Okay.
Yeah. I mean, if we can go through it and get to closure today, then it's just a matter of finding a few couple seconds to minutes to vote. So
Yeah, because I know there's urgency, especially from OPR on these provisions.
Very
to get them out
definitely.
there.
Yeah. So why don't we do this, Jen? What time is it? Yeah, we have time. I think it would be extremely helpful. We've been through the two little problem areas of the bill. Can we just scoot through the bill from top to bottom and remind us what's here at the 5 to 10,000 foot level?
Got it.
Yeah.
Sure. All right, so we're back up at the top. This is section 1 of the bill amending Act 91 and all of the others that came after. For the most part, this is extending dates from March 31st, 2022 to March 31st, 2023. The first section is directing AHS to consider modifying its existing rules or adopting emergency rules to deal with issues under its jurisdiction. Section 3 is on protecting the non-healthcare professional employees of healthcare facilities and human services providers. And this also would expand the directive to be following guidance, not just from the health department, but general state and federal public health guidance on measures to address employee safety. Section 4 would extend the authority or the permissive authority for the Secretary of Human Services to waive or permit variances from a number of state rules and standards governing healthcare and human service providers. It gives a list and a catch-all at the end. Section 5 is allowing the Green Mountain Care Board to waive or permit variances from statutes and rules, guidance, and standards through March 31st, 2023. This is a provision that had expired. This would now put it back into effect and have it go through a date certain. So it would allow the board to waive or permit variances from aspects of its hospital budget review, certificates of need, health insurance rate review, and ACO certification and budget review. And then it would add this new language saying that as part of any proceeding conducted on or after February 1st of this year to establish or enforce a hospital's FY22 or 23 budget, the board must consider the hospital's extraordinary labor costs and investments, as well as the impacts of those costs and investments on the affordability of healthcare. Section 6 we just looked at. This is the relaxation of provider enrollment requirements and provider credentialing requirements. Section 8 is DFR's emergency rulemaking authority, and this would extend for an additional year the authority for DFR to adopt emergency rules to expand health insurance coverage and waive or limit cost sharing requirements directly related to COVID diagnosis, treatment, and prevention, and to modifying or suspending health insurance plan deductibles for prescription drugs to the extent that that would be permitted under federal law. Section 9 we just looked at, that is the early refill of maintenance medications. Section 12 is allowing, to the extent permitted under federal law, a healthcare professional to authorize renewal of an existing buprenorphine prescription without requiring an office visit. Section 13 would extend the date for the Agency of Human Services Authority to reimburse bed hold days at Medicaid-funded long-term care facilities and other 24-hour day programs. Section 17 is OPR on the Board of Medical Practice, or this is around out-of-state healthcare professionals, and this would extend through March 31st, 2023, a healthcare professional, the authority of a healthcare professional who is licensed in another state or U.S. jurisdiction to provide services to a patient located in Vermont as a volunteer member of the Medical Reserve Corps, or for a period not to exceed 6 months as part of the staff of a licensed facility, other healthcare facility, or FQHC. This takes telehealth out of this scope because it adds it in separately at the end of the bill. So extending those dates and adding this 6-month limitation for someone who's delivering services in a facility or other setting like home health in Vermont, but not for the volunteers with the Medical Reserve Corps. And extending the date for the board and OPR to provide notice that this is going to be expiring. And then there's this new language at the end saying that nothing in this section is intended to limit, restrict, or modify application of existing or future federal waivers of healthcare professional licensure requirements to licensed and certified facilities. This was specifically to address the concern around the federal waiver for the skilled nursing facilities, the nursing homes for, I think, nurse aides. Section 18 is reactivating in some form the license, certificate, or registration of a former Vermont licensee whose license became inactive in the first case within the last 3 years, would allow them to start providing services again using telehealth or as a volunteer member of the Medical Reserve Corps or in a Vermont facility. And then also having that similar flexibility for former healthcare professionals who went inactive between 3 and 10 years ago to return to the workforce on a temporary basis with an OPR or Board of Medical Practice temporary license. Section 20 extends the authority of OPR and the Board of Medical Practice to have emergency authority to act for their regulatory boards if the boards can't meet. Section 21 extends the ongoing authority of OPR and the Commissioner of Health to issue emergency regulatory orders as necessary to protect public health, safety, and welfare. And then finally, from Act 91, this is the telehealth provisions and the language. This would extend the ability for providers to deliver services, healthcare services using a non-HIPAA compliant connection if it's not practicable to use a HIPAA compliant connection under the circumstances. And this is to the extent that that waiver is permitted by federal law or guidance regarding enforcement discretion, which is the way CMS has been, or Health and Human Services has been implementing this. And then striking out the language that currently or had allowed during and for 60 days following a state of emergency in Vermont as a result of COVID-19, the waiver of the informed consent requirements for telehealth if it was not practicable under the circumstances. So this flexibility would no longer be there if there is a future state of emergency for COVID-19. Then we get to section 2 of the bill, which is amending sections added in Act 140 of 2020. This allows the Board of Medical Practice or its executive director to issue temporary licenses to out-of-state physicians, physician assistants, and podiatrists, and to waive some requirements for physician assistants during that time. Section 3 is amending another 2020 act. This is to extend the authority of pharmacists to order and administer COVID tests. So this would allow that authority to extend until March 31st, 2023. Section 4 also extends, because this was added in last year's Act 6, the authority of DFR to issue emergency or adopt emergency rules on health insurance coverage and reimbursement for telephone calls used to determine whether an office visit or other service is needed. Refer to these as telephone triage services. Then we get to the new telehealth provisions, and these are the kind of bridge provisions getting through until the provisions of Act 650 or H655, which is still in the House. So this would first extend just exactly what the current state is through March 31st of 2022. This is allowing a healthcare professional licensed somewhere else in the US as being deemed to be licensed, certified, or registered to provide services here with the same provisions we have in our existing law in the earlier part of Act 91 that we looked at. So those same provisions, and then, but just specific to telehealth, and then specifying that this section remains in effect through March 31st, as long as the healthcare professional remains licensed, certified, or registered in good standing. And then beginning on April 1st of this year and continuing through June 30th of 2023, the professional would need to register with OPR or the Board of Medical Practice, and the section we'll look at next, in order to provide or continue to provide healthcare services to one or more patients located in Vermont. So then this points us right to section 6, and that is the temporary telehealth registration for out-of-state healthcare professionals. And this sets out the process from April 1st, 2022 through June 30th, 2023. OPR and the Board of Medical Practice shall register a healthcare professional who is not licensed or registered to practice in Vermont, but who seeks to provide services to patients or clients in Vermont using telehealth, as long as they complete the application in the manner specified by OPR or the Board of Medical Practice, and they hold an active, unencumbered license, certificate, or registration in at least one other U.S. jurisdiction to practice the profession that they're seeking to practice using telehealth in Vermont. And their license, certificate, or registration is in good practice everywhere they hold one. And they provide verification of their licensure to OPR or the board. And then finally, section 7 extends the authorization or the validity of advance directives executed, in this case, through March 31st, 2023, even if the witness or witnesses and the explainer, if needed, were remote when they provided the witnessing or the explanation of the advance directive. And it would take effect on passage.
Okay, why don't we take that down? And thank you. That was exactly the level we needed to hear the bill.
Okay.
Yeah, that was perfect. Thank you, Jen. So here's my suggestion, committee. Any further comments or questions of Jen?
Do you ever record? You should just play a recording of yourself. You've gone through that bill more than any bill probably ever.
Probably true.
So
Great idea. I like it.
That's good. Thank you. So we're, as we said, I'll check in with the chair of House Healthcare, and then we'll come back to this either tomorrow or the next day for a proposal to vote on the bill. So we need to move on it quickly and then get it to the governor's desk. It's an important bill. Okay, here's my next suggestion that I'm sure we'll all vote no on, and which is I think we'll take a break. Yeah, so let's do that, and just we'll come back at to S90 at 10:30. If we come back at 10:29, that'd be helpful. Okay, anything else? No, we're good. All right, thank you.